good morning. This is our presentation for EM debates. Chris and I are presenting. The topic is stones to image or not. This is also our last presentation for residency. We also want to say special thanks to the EM debates team, Drs. D'Souza, Eden Kim, Dr. Allen, and Navas for that help with this presentation. So now you're seeing this patient in the ED. What's the first image you're going to grab? Are you even going to grab any imaging? If you are going to grab an image, are you going to get ultrasound or the CT? Or are you going to be like, maybe I need a psych consult? So this is going to be our table of contents for this presentation. We're going to talk about first, why is this even a controversy? We're going to talk the proponent propose that you don't need imaging. And then Chris, obviously our ultrasound fellow, is going to argue that ultrasound is all you need. And lastly, we're going to talk about the benefits of CT, or why you should get a CT. So first off, why is this even a controversy? Let's establish some background. Kidney stones are a chronic episodic disease. A majority of patients eventually have multiple episodes. 1 in 11 Americans will have kidney stones, and the average age is 44. Of note, the ED visit for kidney stones is the most expensive of the top 10 most common visits, resulting in discharge. $3,000 to $4,000 is due to the frequent use of CT. It's estimated that over 2 million CTs are performed annually for ED patients with suspected stones. It's also estimated that the radiation from one non-con abdominal CT causes one cancer for every 500 to 1,000 CT scans performed in adults ages 20 to 40. So we hear all this badness about CAT scans. It increases healthcare costs, it causes radiation. Then why is there this mantra in medicine that every first-time kidney stone requires a CT scan? In the urology guidelines says that a non-con CT scan is a preferential initial imaging study for the index patient. This has level A evidence, as it has the CT scan has high sensitivity and specificity compared to other modalities. And of note, on their algorithm, they have few exceptions. It includes known radiopaque stones, contrast allergy, renal insufficiency, if they're pregnant, and if they're a pediatric patient. There's also a cultural aspect that patients and doctors are pro-CT. In a study to develop a decision aid to assist with shared decision-making regarding CT imaging, and this was in particular for patients who had kidney stones or had a suspected diagnosis of kidney stone, it was found that 1, patients had a preconceived bias in favor of CT scan. They thought that the CT scan gave them a degree of certainty, and that by getting the CAT scan, the doctor was taking them seriously. Second, the physicians perceive that CT is 1, the path of least resistance, 2, that the CT is the default or standard of care, and that they perceive that the urologist would need the CT scan. So let's get on with the debate. Kidney stones, do you even need an image? And if we're going to image, should we get an ultrasound or CAT scan? So we're going to make the argument for no imaging. First, I would argue that you don't need imaging, and I would support this with a clinical prediction rule called the Stone score, which was published in 2014 and has 4 external validation studies. This study did a derivation and validation of this prediction rule and for the presence of uncomplicated kidney stones in patients eligible for CT. Their hypothesis was that patients who have a high probability of having a kidney stone have a low probability of having a acutely important alternative finding. The study design was a retrospective cohort with 1,040 patients from 2 Northeast ED visits with the prospective validation with 491 patients. The inclusion criteria was that the chief complaint was flank pain and that they received a kidney stone CT scan. There were some exclusion criteria. The first is that if the patient had evidence of infection, fever, or leukocytes on urine dipstick, recent trauma or a recent or history of a urological surgery, active malignancy, lack of flank or back pain, and known kidney disease creatinine greater than 1.5. The stone score is based on 5 factors with a score of 0 to 13. The low score is 0 to 5, moderate is 6 to 9, and high is 10 to 13. This graph, just so you guys can orient yourself to what this graph is showing, it shows that the prevalence of a kidney stone by stone score category in the derivation and validation cohorts. The percentages at the top of the bars indicate the prevalence of kidney stones. And then the values under the bars indicate the number of patients that ended up in each set. So about 15 to 20% of low risk were of the patients, and moderate was about 50%, give or take, and then high was about 30%. So in both sets, the derivation and validation, they found that in the low categories, the low stone score categories, only 8.3 and 9.2% respectively had a kidney stone. In the moderate, 51 and about 51%, both sets, and high was about 89%. Of note that they did find acutely important alternative cause of symptoms for the patient having a flank pain, and they found on all CTs that overall that was 2.9% in the validation group and 3.7% in the derivation group. But then if you just stratify that within the the high stone score group, the derivation group only had 0.3% of acutely important alternate cause of symptoms, and then in the validation group is 1.6%. So the argument is that the stone score accurately predicts likelihood of kidney stones and is adversely associated with the likelihood of acutely important alternative cause of symptoms. That's a mouthful. So if your stone score is high, the probability of having a scary alternate cause of symptoms was about only 0.3% in the derivation group and 1.6% in the validation group. So their argument was that if 1.6% in the high stone score group is less than 2%, which is the testing threshold, point at which the negatives of a test outweigh the positive, for example, for the CT, for example, for CTA-PE, what we do for our PE patients, or our suspected PE patients, then they would argue that this score is helpful. But ultimately, this study said that the clinical prediction rule could help the clinician, the provider, to decide to balance the risk of testing, so the exposure of radiation, with the resources that it requires, e.g. length of stay, waiting for the CT scan, and the cost to patient, against the uncertainty and risk of misdiagnosis. The study also suggests that young patients who are more susceptible to radiation and less likely to have significant alternate diagnosis, that this score might help. Sounds great, right? But be aware of some limitations of this study. Like I said, that the derivation and validation study were within the same clinical setting. This may not be applicable to our patient population. It's 84% of the patient population was white and only 11% was Black. And it's unknown if a Gestalt clinician pretest probability would perform similarly to the objective clinical prediction rule. One of the four external validation scores that was performed was a retrospective chart review in a Korean patient population. And they eventually said that the stone score performed similarly and was able to risk stratify. But they modified the score. Instead of including race and nausea and vomiting, they included CRP less than 0.5 and a history of kidney stones. Here, the inclusion criteria was a final clinical diagnosis and of flank pain and a CT scan. Their exclusion criteria were as similarly as the original article. As I mentioned before, so in this study, the prevalence of kidney stones was much, much higher than the original stone score, as you can see. Of note, during that same time frame, there was a campaign in Korea that there was to reduce radiation and cost of imaging. So those who were studied had a high suspicion of kidney stone in the first place. And then So they found that 79% of those patients that they studied had a stone, 21% did not have a stone or had a alternative finding on their CT scan. 11% of those CT scan findings were insignificant, but 9.6%, about 10%, found other clinical significant findings versus the stone score original paper, which is 3.7%. Of note, among the high stone score group, their significant alternate diagnosis was half of the original stone score, which is the bottom graph, which is a little hard to see, so sorry about that. But they found in a duration score 1.9% and in the validation 0.7%. Some of the limitations for this, as you guys know, it's in a largely Korean patient population. This was in Korea. When you read the paper, the methods are not super clear if they were blinded. There was a selective bias with the campaign going on at the time, and it is retrospective. So in conclusion, based on all this, a lot of verbiage I said to you guys, based on the study, 4 external validation scores, I would feel comfortable using a stone score to discharge well-appearing healthy patients with a high stone score and good pain control. The risk of the acute alternate diagnosis is 1.6%, which is less than 2%, which is what we use to decide, is the risk of CT radiation outweighs the benefit of the CT. You can also use this as shared decision-making with the patient and to buffer your chart. People who put PERC-neg in their chart are well scored. But like I said, there are some limitations to both of these.
All right, to keep going with the no imaging debates, ACEP actually released the Choosing Wisely Guideline, and they actually recommend that you should avoid ordering the CT ab and pelvis in young, otherwise healthy patients less than 50 years old who have no history of kidney stones that are presenting with symptoms consistent with uncomplicated renal colic. And there's some studies to back this up. There's 3 studies in particular. So there's this first one that looked at young patients that were suspected to have uncomplicated kidney stones. So they looked at a retrospective chart review of 18 to 50-year-olds. They did 115 CAT scans. And out of those 115 CAT scans, there actually was 0 findings that were considered to be emergent or urgent, such as needing surgery, antibiotics, or admission. There were 11 admissions, however, and 7 of those required urologic procedures. And they did mention in the paper that all of those procedures were due to inadequate pain control. The next study actually looked at the younger patients using the stone score. So they looked at all young patients between 18 and 50 years old. They had 134 patients that received CT scans evaluating for renal colic. There were 52% of those CAT scans were positive for a kidney stone. And in the low stone group, they found 13% had stones, in the moderate group, 58%, and in the high group, 89%. So basically with a score of 10 or higher, they had a positive predictor value for having a stone of about 90%, and then a stone score of 6 or lower for younger patients, there was a negative predictor value of about 84%. Also in this study, there were 0 cases of dangerous alternative findings that needed surgery, antibiotics, or admission. It was a small study, but just something usually younger patients don't have alternate dangerous findings on their CAT scan. So you may not need a CAT scan then. There was another study that looked at people who were already diagnosed with kidney stones and are now coming back for similar symptoms. So this was a retrospective study of young patients, again, 18 to 50. So there was 230 of them. And on the repeat CT scan, 82% of them did not have any change in diagnosis. 11% had a change in diagnosis that did not require any intervention, with musculoskeletal pain being the highest diagnosis in that group. And 6.5, about 15 patients did have an alternate diagnosis requiring intervention, but 7 of those 15, it ended up being pyelo, which you can assess using the UA. And the other ones were diverticulitis, appendicitis, SBO, pneumonia, and cholecystitis. So like I mentioned, just getting a UA, you could drop your alternate diagnosis down by 3.5%. And also I can argue that using ultrasound to assess these other things like cholecystitis, even appendicitis, SBO can decrease your chances of missing an alternate diagnosis. So basically, in summary, who doesn't need imaging based on these studies? So if you have a healthy patient less than 50, if they had a recurrent kidney stone, and if they have a high stone score. So now I'm going to argue which patients just need ultrasound. So, because if you're not comfortable with the data and you want to make your patient a little happier and you want to choose some type of imaging modality, I'm going to show you some studies that actually favor ultrasound. So just of note, these are the two ultrasound fellows next year. Works me on the left, and then Allison Lee coming from Jacobi on the right. So to convince you that ultrasound may be better than CAT scan, I'm going to convince you why CAT scans are dangerous. So on the chart on the left here, that's showing your risk of death due to cancer based on the timing that you got one CT scan. So as you can see on the left here, the younger you are at the age of your time of CT, the more chance of you dying from some type of cancer. And on the right here, that's showing your lifetime risk of dying from colon cancer and lung cancer based on the age at the time you were exposed to your CAT scan. This was ultimately derived from studies from survivors from the atomic bombing, because it's such a hard topic to study since it requires years of follow-up. So there is a landmark paper studying actually ultrasound versus CAT scan for suspected kidney stones. This was done in 2014. It's a very large study, multi-centered. It was randomized, and it included patients 18 to 76 years old that were complaining of flank pain or abdominal pain, and the ED doctor decided to get an imaging to establish or rule out a kidney stone. Some important exclusion criteria were that they, if they were considering cholecystitis, appendicitis, AAA, or any bowel disorders such as the SBO, they were excluded, and patients with high BMI, like males greater than 129 kilograms and females greater than 113 kilograms. If they had one kidney, if they had a history of renal transplant, or if they were on dialysis, they were excluded. So what they did, they put these patients in 3 different arms. So the first arm, and it was about 900 in each arm. The first arm was just a point of care ultrasound done by the ED physician. The middle arm was a radiology ultrasound, and the third arm was a CAT scan. What they were looking for were any high risk diagnosis with complication. Remember, they excluded those patients who they thought had coli, AAAs, pneumonia. So they looked for the complications from these things, such as sepsis due to pneumonia, perforated diverticulitis. And what they found was that only 0.4% out of all these patients, out of all 3 arms, had any high-risk diagnosis after 30 days, and there was no difference between the 3 arms. There was also no difference in serious adverse events, like anything that caused death, life-threatening conditions, required hospitalization, or needed any medical or surgical intervention, or even any related adverse events, such as those things that they tried to exclude, coli, API, and SBO. However, one thing that they did find significantly significant was CT radiation in the CT arm, of course. So, like I said, there was no difference in adverse events or diagnostic accuracy between all 3 study arms, although there was increase in CT radiation in the CT arm over time, overall follow-up. So the majority, what this paper showed is that the majority of patients that come to the ER complaining of flank pain consistent with kidney stone do well independent of whatever testing that you get. Therefore, just applying ultrasound first could help lower the cumulative radiation exposure by decreasing CT usage. So there were a couple of studies that actually looked at using ultrasound first as a protocol. So there's this one done in Korea that used point of care ultrasound first for, or they randomized patients. On odd days, they used labs and UA to decide, to help with the ED physician to decide if they're going to get imaging. And on even days, they used ultrasound. If there was hydro, they would get the CT. If there was no hydro, they wouldn't get the CT. There was 147 patients, so it was a smaller study. 87% of them ended up having a stone. And what they found, it was more of a patient-centered outcome. What they found that patients spent less time in the emergency room, about an hour, and their medical bill was less. There was no difference in complications or mixed diagnosis in either group. And also the, just of note, the length of stay was due to the decreased time to actually getting the CAT scan, but not from CAT scan to discharge. So just by using ultrasound can help the physician decide whether or not to get the CAT scan quicker, to get them out of there quicker, and cost them less money. There was another study using the stone score again. So just a reminder of what the stone score entails is here. It is on MD Calc if you guys need to calculate it. So just a reminder, low score is 0 to 5, moderate is 6 to 9, and high is 10 to 13. So what they did was they used the stone score plus ultrasound to see if hydro on ultrasound improved the stone score by identifying patients with kidney stones. They also use ultrasound to see if hydro can correctly identify people who need a urological intervention. So they included all patients that came in for flank pain that were suspected to have a kidney stone. So there were 835 patients. There ended up being 53 kidney stones found on CAT scan, and just of note, 6.5% of those had an alternate diagnosis. They only exclude people who were unable to consent, pregnant patients, prisoners, or anyone who's not speaking English. This chart's a little confusing. I'll explain it a little bit better. There's only two important measurements or results in this chart. But basically what they found was hydro was only sensitive 65% of the time and specific 75% of the time, but moderate or great or severe hydro increased the specificity to 93%. So the big takeaway from this study was that moderate or severe hydro in your low stone score actually increase your likelihood ratio for having a stone, and increase the likelihood ratio of needing urological intervention. What it also showed was that there were 280 patients in the high stone score group. 59 of them required urological intervention, but 11 of those that needed urological intervention did not have hydro. Only 11 of those patients. So basically, if you're in the high stone group and you do not have hydro, you have a very low chance of needing any urological intervention. Therefore, you should not need a CT scan. And based on these findings, they did create an algorithm which used the stone scores. So you have your low stone score here, moderate and high, and then they recommended what you should do based on your ultrasound findings. So basically, your low stones group, if you have no hydro, you should consider some other diagnosis. Sometimes that doesn't require a CT scan. It could be like musculoskeletal pain. But if you have any hydro or modest severe hydro, you should get a CAT scan because they say you could have a kidney stone. In your moderate group, basically, if you have moderate to severe hydro, you should just consider that they probably do have a high likelihood of having a stone. So you probably don't need a CT scan. And anyone in the stone group, high stone score group, does not need a CAT scan because they have a high likelihood of just having a kidney stone. So if they would have applied this algorithm to their patients, they would have eliminated 280 CAT scans. There were 280 high stone scores. And they would also eliminate another 70 CAT scans in the patients with a moderate stone score that had moderate to severe hydro. All right, this is another landmark paper that came out a couple years ago that used the Delphi process consensus. What that is you take a panel of experts, which this paper used 3 ER physicians, 3 radiologists, and 3 urologists, and they gave them scenarios and they asked them what they would do. They let them vote 3 different times, and they let them talk about their vote in between the 3 different votes. And what they did was they see like how well they can agree with each other. So a perfect score was 9, 9 out of 9. Excellent was 8 out of the 9. Good was 6 to 7 of 9, and moderate was 5 out of the 9. 80% of the time they were in excellent agreement, with 8 of the 9 agreeing with each other. This article was the first systematic multi-specialty evidence-based consensus in regards to imaging in renal colic. So I'm just going to go, there were 29 scenarios. I'm not going to go through all of them, but I picked some out that I thought were very interesting. So this first one here was a younger patient 35 years old, who had a history of kidney stones. That his flank pain started about 3 hours ago. He was nauseous. He had hematuria on his UA. And they asked them, and his pain was relieved with pain medication. And they asked the experts, what would you do? And there was moderate agreement that 5 out of the 9 of them would use ultrasound, or 4 of them would do no imaging at all. And interesting enough, though, no matter what they found on ultrasound, if there was hydro or no hydro, all of them agreed, perfect consensus, that neither would get further imaging. What I also found interesting is that, so in this case, there was a 35-year-old gentleman, no history of kidney stones, very, very similar story. They all agreed that they would all start with ultrasound. But then when they did the ultrasound and they found no hydro, 8 out of the 9 agreed that they also would do no imaging. I found this interesting because they pointed out that the one person who decided to get imaging if they did not see hydro was the ED physician. And it just goes in with that teaching that every first stone requires a CAT scan, but even our consultants, the experts at this, the urologists, also said that they probably wouldn't obtain a CT scan in a first-time stone, that the pain was relieved and there was no hydro. This is in the older patient scenarios, all the 75-year-olds, they all agreed, mostly agreed in the good in the last one, that they would get CT scans regardless if they have a history of kidney stones or not. For your moderately aged patients, your 55-year-olds, they all agreed that if they had no history of kidney stone, even if the pain was relieved, they'd probably still get a CAT scan, just because of the higher chance of having an alternate diagnosis. Although if they had any history of kidney stones and their pain was relieved with pain medication, they probably would get an ultrasound or even no imaging at all. Two of the scenarios that I found interesting were that they looked at younger patients who had urological procedures, one a lithotripsy and the other stent placement, who came in for flank pain. And they all kind of agreed that they would just use ultrasound looking for hydro or not. So if they did not see hydro, they knew that the procedure worked or the stent is working. Or if they did see hydro, they realized that they're probably not working. You should get to your urologist and maybe a CAT scan after that. So just to summarize the pro-ultrasound group here. So ultrasound first will not miss many alternative diagnoses and reduce CT radiation. It will quicken your dispo by about an hour and save your patients money. If you use the stone score plus ultrasound, it can help, and use their algorithm, and it can help you risk stratify your patients, and also just help with shared decision making with your patients. And experts agree. So you can ultrasound your younger patients, your patients with history of stone, or even patients who had recent urological procedures. I'm going to turn it over to Priscilla, who's going to argue for CAT scan now.
All right, we're almost there, guys. So what's the argument for CAT scan? Why should we get the CAT scan? So the CAT scan is the gold standard. The CT scan has a specificity of 94 to 99% and a sensitivity of 95 to 98%. But we just told you about all this radiation. So when does the risk of having a bad diagnosis outweigh the radiation risk? I would argue any patient that has a condition that was excluded from the studies, which was pretty extensive exclusion. If they were pregnant, they had a high risk for an important non-stone diagnosis, but like the ones that Chris mentioned in the ultrasound studies, for example, SBO, appendicitis, cholecystitis, etc. If the patient had a history of a kidney transplant, dialysis, known solitary kidney, for those who had a weight BMI, high BMI, for men greater than 129 kilos, for women greater than 113 kilos. Fever, which you must be aware, the original stone studies had febrile patients were excluded. This included subjective and measured fevers. Any evidence of infection on UA, recent trauma, or urological surgery, and active malignancy. One study was a retrospective study of 215, which is a small study, 215 CT scans. They call it CTKUB, kidney, ureter, bladder, which I read through, and it looks like it's also known CT abdomen pelvis. They just have a specific name for it. A tertiary care center in Australia for clinically suspected renal stones. They had 16 findings, but here they calculate as 15 because one of the patients had two diagnoses, inguinal hernia and acute coli. They found that in their entire 215 patient, 215 retrospective study, that there's 33.5% of alternate radiographic findings. And those 15, which is listed here, 7%, when they calculate 15 out of 215, had clinically important alternative pathology requiring acute management. And then this is from the earlier section of this this presentation. If you have a low stone, I would argue that you should get a CAT scan if you have a low stone score, which means that you have a high chance of an acute alternate finding. Lastly, funny thing, the original stone score had 4 external validation studies. One of the studies said you cannot use this to say no CT scan because The initial study did not include sensitivity or specificity, and if you remember from med school or EBM, a clinical decision rule to rule in a kidney stone should have excellent specificity. So this validation study, their goal was to determine if a score can be used safely to decrease CT scan use in suspected stone. They used the same data from the multi-center RCT that the original stone score was derived and validated in, and they argue that a decision rule to ID patients with kidney stones without need for further testing should require high specificity. You guys remember the acronym SPIN, specificity rule in, and a positive likelihood ratio. Stone score does have a superior specificity compared to physician Gestalt, which is this chart here. They're showing the stone score in the Gestalt, but it has a poor sensitivity, 53%, and a moderate specificity of 87%, which was not sufficiently high, was not sufficient specificity to defer CT scan. With that said, we must be aware, and I want you guys to be aware, that all these studies included patients that had a suspected kidney stone, which means that the clinician already had a high pretest probability. So a patient with flank pain and stone is already on your differential. If it's not your number one diagnosis, these protocols may not be helpful. Also, if you see here, they put likelihood ratios that, we have to remember which cutoffs for likelihood ratio diagnosis. A diagnostic test will alter your post-test probability. So if you already have a high pretest probability and a low negative likelihood ratio, it's not going to change your post-test probability. Last but not least, one study, this was an interesting study I found that I would argue you should get this CAT scan if you really have a high suspicion that your patient's going to need urology or urological intervention. Not just urology, a urological intervention. In a multi-center RCT that assessed the rates of urological referral and intervention, they try to elucidate whether the initial diagnostic imaging modality affected the management of the kidney stone. They found that an odds ratio of 2.55, that a patient who had a point-of-care ultrasound performed by an EM physician as an initial diagnosis test was likely to have a CT scan before intervention, as opposed to an ultrasound performed by radiology. So they argue that EM's point-of-care ultrasound lacks labeling, measurements, and detailed anatomical visualization needed by urology to feel comfortable proceeding with the surgery without CT scan. 78% patients had CT scan before elective intervention. So you can make the argument that performing a bedside ultrasound in ED would decrease length of stay, but doesn't necessarily decrease the patient's radiation exposure, as he or she will likely get a CT prior to urological intervention, especially if you suspect that patient will need a uro intervention. Now, if you're going to obtain ultrasound by radiology, this would decrease their radiation, but may increase their ED length of stay. So the pro-CT summary, I would argue all the excluded patients from studies, you may want to consider getting a CT scan. If you have a low stone score, you do the clinical prediction rule and use the clinical decision rule. You get a low stone score, they have a high percent of an acute alternate finding. And then if you anticipate they will likely need a urological intervention, if they're there, if you want to get the CAT scan so that they expedite their care when they go to clinic. Now, this is probably how all you are feeling after listening to us mess up this stone scores, high stone score, whatnot. And this is how we felt after going through all the literature. So there's no right answer, and that's why it's a debate. It's similar to when you get a Roche review question and they ask you what's the management, and you're thinking, it depends. Same thing applies here.
All right, so basically in summary, we just wanted to provide our recommendations based on all the papers that we went through. We went through over 20 papers. There's a lot of studies on this. So basically for your no imaging group, you can argue that if they're healthy, they're less than 50, they're back for recurrent stone pain, or if they have a high stone score, you will not need to get any imaging. They're most likely going to do fine. You can argue that you can start with ultrasound for your younger, healthier patients that do have a history of kidney stone, or even recent urological procedure like lithotripsy or stent placements. It will save your patients time, money, and CT radiation. And if you use the stone score plus ultrasound algorithm, it can help risk stratify your patients and save patients the CT scans. We do think that you should still CAT scan some of these patients, especially those that were excluded from all the studies as it's not tested. Those who have a low stone score, as they have a higher chance of having an alternate diagnosis, and those that you suspect are going to need to go for urology intervention because they're probably going to get a CAT scan anyways. So I just want to say, well, Trudy and my new furry daughter want to say thank you for listening and staying awake. Now we're going to open it up to everyone if you have any questions or comments.
I think a big thing to remember is that this may not seem like a really big deal in our patient population, but if you practice emergency medicine in other places, mostly because renal kidney stones are a more Caucasian issue, this is going to be a larger part of your practice. And it's hard to get a high stone score in our hospital as well, because if you go through the MD Cap, which we just practiced a minute ago, is that the race is a significant aspect to it. So most of your patients here are going to be moderate.
Yeah, female non-Caucasian patients, based on this score, will never get to the high point range, no matter what your other scores are.
There was one study that they used a different patient population, and it was like multiple races and not as many Caucasians. And if you go on the MD Calc, they actually have a comment or a qualification saying that race may not be a factor that they would say you could or could not use it, because this other study said that it's just as applicable in patients who are Black.
But I mean, I think you shouldn't rush to CT in a young person that you're considering kidney stone. I think the biggest thing when I started trying to incorporate this in my practice, and maybe Chris, you can comment on this since you're pro ultrasound, is what to do with the ultrasound results. And you had one or two slides that kind of talked about it, but that's, I think, always the most confusing aspect of it is that, okay, I do the ultrasound, I see hydro. Does that mean I should CT them because they could have obstruction, or does that mean they have a kidney stone shouldn't? I think that's always something physicians struggle with.
This just came up in our group chat, and Charles was saying he's seen more on the West Coast that mild hydro, it's for them more reassuring, like, oh, like, yeah, hydro works with kidney stone, but also probably not huge. And if they see moderate to severe, they go to CT. But my issue is, like, I don't know how to tell mild to moderate to severe very well. I can kind of tell you if there's hydro or not. I don't really read it very well.
Well, isn't it true that if you have pain, it's from hydro?
Hydro, because
So if you're going to get into the study, you had flank pain, you have hydro at some point. So, you know, my argument is if you have hydro, then that's what you have.
Yeah.
What I tell patients is, I tell them whether you have a kidney stone or if you have a kidney stone, most will pass in 2 weeks, right? So 80% of kidney stones will pass in 2 weeks. If you talk to urologists, just don't send it to me for 2 weeks, because in those 2 weeks, 80% will pass and they won't need me at all. The ones that don't pass in 2 weeks, they're going to need another study anyway. So what I tell the patient is wait 2 weeks. And then in 2 weeks, if you still have pain or you're still worried about it, we're going to get a CAT scan. But right now, getting a CAT scan for someone who feels okay, who's going to go home, who doesn't have any alternative diagnosis that you're worried about, then if the stone passes, they're not going to need a CAT scan. So then they'll never need a CAT scan. And the ones who will need a CAT scan, I've saved them 1 CAT scan. So I make the argument, I can save you 1 CAT scan now, and that you may never need another CAT scan again. And if you have recurrent pain, then you probably still have a kidney stone. But if you have recurrent pain, nausea, fever, then you're going to need a CAT scan in that 2-week period. So you might as well just wait.
So if 80% are going to pass, you're not as concerned about size.
No, the size, it really doesn't matter, because 80% will pass. 80% are less than, 0.5 millimeters, so it's going to pass. So
even if it's 8 millimeters, and there's less likelihood of that, it can still pass. And they're not going to take the patient to the OR today.
Right.
If they have an 8 millimeter, even a 1 centimeter stone, I've seen them say, hey,
Right.
let's see what happens.
yeah, I mean, the stone could break up by itself and pass eventually. So I always say, let's wait 2 weeks and see what happens. And, I don't do CAT scans on many of these patients. What if the patient says, I really want a CAT scan? It's hard to say no, even for me. But I do tell them the risk of radiation and the risk of waiting in the emergency department for the next 6 hours.
Would cover.
And you can ultrasound them and make them feel better too.
Yeah.
So you did some type of.
No, I think that's after the
Yeah.
ultrasound. I think.
No, I-
and I agree
I-
with Dr. Sinner. I think it's when you, whatever result you get, it's confirmatory, and then you talk to the patient about the implications.
Right.
I think you really have to risk stratify your patients, not just the risk of having a stone, but there's just a risk in general.
Right.
And I think the huge caveat here is there any concern for infection,
Right.
you have to approach that patient extraordinarily different.
Right.
You really have to look for any clinical signs of infection. I'm not a huge fan of UAs as a whole, but if there's any sign of infection on a UA and someone you think has a stone, like that stone has to come out if it's infected now. Otherwise, we've had several evidence on stones that were not removed right away. Those patients go septic really quickly, and it's really bad too. That is the big caveat. This is for the non-infected stone, and I think you have to, look at each patient individual. I think we are so used to telling somebody definitively that they have a stone because we see it on CAT scan. I think it's okay to say, look, your story sounds like you have a kidney stone. Let's treat that like that. Let's give it some time, and it's okay.
It also goes
It's
to
okay to not be
blood work.
100% sure of your diagnosis.
It also, there's no reason to order blood work like your first kidney stone.
Right.
I mean, the creatinine doesn't go up. If I tie off one ureter, right, your creatinine doesn't change. Because
We
the
see
other
that with
kidney-
solitary kidney.
Right, the other kidney is going to take over just fine. Looking for a white count to tell you infection is just silly. Looking for primary hypercalcemia in the population is pretty rare, and we can find it out later. There's no reason to do it. If they're not having other symptoms of hypercalcemia, and you got to have symptoms of hypercalcemia above 14 or 15, they're symptomatic. This is not primary hypercalcemia, primary hyperparathyroidism. This is some malignancy, and I don't think you're going to pick it up on the first kidney stone. So, and even UA, to see white cells in your urine, there's no study that tells you plus or minus whether it's infected or not.
Right.
Most kidney stones are not infected because you just don't get infected kidney stones unless you have some infection causing the kidney stone. You don't get an infection from a kidney stone. You get a primary infection causing a kidney stone. And those are Proteus, those are people who are bed-bound, and with multiple kidney infections. To see a infected kidney stone as a primary complication of your run-of-the-mill kidney stone probably doesn't happen. So even if you want to order the UA to see hematuria, well, that's great. But I think giving antibiotics for a few white cells with the hematuria, remember, if you're bleeding red cells and white cells, and there's an inflammatory response in the ureter for having the kidney stone.
Yeah.
So I don't think I think we're over-treating people who have white cells in their urine, even if they have a kidney stone. And doing blood work, I think, doesn't tell you anything. I would wait 2 weeks and say, if the kidney stone gets better, go to your PMD, get a routine lab test, because it's nice to know if you have primary hyperparathyroidism. So that's kind of the most common electrolyte abnormality causing kidney stones, right? You can a type 4 RTA, I don't think you're going to find. So those are the ones to do this test. So I always tell them, I said, I'm pretty sure you have a kidney stone. The pain is controlled. You don't have a fever. You're a healthy person otherwise. Let's wait 2 weeks and see what happens.
Yeah, similar to Center, I think the experts would also agree that younger patients, if their pain is controlled, it's okay to give them a trial of passage. And you just save them a CT scan.
Yeah, and whether to put them on Flomax or not is another debatable point. Flomax doesn't help stones that are going to pass anyway.
Yeah,
So
that's a whole other topic.
I think the other thing to know in different practice settings, and you'll learn the culture of wherever you work, is that you may have some hungry urologists, and this is a moneymaker in some institutions doing lithotripsy, and what Dr. Schechter said, they won't take them to the OR that day. There's places where they will, where you'll call urology and they'll be like, yeah, no problem, put them on ab surge, I'll do lithotripsy and be discharged later that day or tomorrow.
It's funny that you say that, because there was definitely a study that showed that, I didn't include it in this because it didn't really benefit any of the sites, but that they found that if the hospital had more urologists, you definitely had more CT scans and you definitely had more interventions.
And I'm not saying that's the right medicine, but where you'll all work as employees in different places, so you have to know what.
they're probably got a cardiac cath too while they're
Yeah,
waiting.
exactly.
Yeah.
Exactly. They'll get a.
At least cardio-
While you're here. I'm gonna push you through the CAT scan, see the coronary arteries, we're gonna cath too.
So just to summarize, if you guys didn't hear, Dr. Willis and Dr. Hassel mentioned, be aware that the score may not be applicable to our patient population. Dr. Sinnott said, his patients who are classic for kidney stone don't have any infection. They don't, he recommends 2 weeks. And then, if you get infection or fever, come back and maybe you need a CT scan then. Or if it gets better, go to your PMD. The UA, don't need to get a UA, don't need to get basic blood work. And then the concern that was brought up by Dr. Willis is that, you get the ultrasound and you get some hydro, what do you do with it? And then one of our graduates who is a ultrasound, did he graduate? Charles Murchison is at UCSD as a ultrasound fellow who's graduating, said that on the West Coast, mild hydro is reassuring, but moderate and severe are go to CT. And then Dr. Schechter said, look at your patient individually.
Did we have?
Discharge.
Can I also add one thing?
Yep, sure.
Who is it?
This was really helpful. Well done. Congratulations. This was great. My only suggestion is that when you in such debates, when you present the studies, mention a few sentences about the methodology of the studies, because just because something is published doesn't mean it's not garbage. We can't believe everything that is published. And no offense to Chris, but ultrasound studies, there are a lot of biases, the spectrum, the selection bias and unblinding and other things. So you have to be more, but the studies that you presented today, they were actually solid studies. But in general, I suggest that in debates, when we present a study, mention something about the methodology and how valid you think the results are.
Thank you, Sam.
Thank you. Dr. G?
Yeah, I just want to say one caveat. I agree with most of the things that were said. Just again, and I've heard Dr. Z say this also actually, you also have to put a lot of credence on your history and physical. If something is not making sense, don't keep anchoring that this is a stone. I have seen aortic aneurysms that seem to look like stones. Not saying that you need to get a CTA on everybody who has classical pain, but if it's a 70-year-old person who never had a stone before and it's going toward their back and it's not classical, think again. I've seen appendicitis, and especially I've seen 2 cases of ovarian torsion that were thought to be stone. So, and one of a testicular torsion that was thought to be a stone. So you got to do a good history, you got to do a good physical, and if it bothers you and you think it could be something else, really does, then you have to go further.
Okay, thank you.
Thank you.